Tonight we are very privileged to have Guilia Marini, who's from Italy, to speak to us. Maria is an epidemiologist and a counsellor in transactional analysis with 30 years of professional life in healthcare. She has a classic humanistic background, including knowledge of ancient Greek and Latin, which opened the path to studying languages and arts and to becoming an art coach. She then followed academic studies in clinical pharmacology, specializing in epidemiology at the University of Milan and Pavia. Her past international experiences include time spent at Harvard Medical School and in a pharma company in Mainz in Germany. Maria is Director of Innovation in the healthcare area of Fondazione ISTUD, a Centre for Educational and Social and Healthcare Research. She's the President of UNAMS, which is the European Narrative Medicine Society, and is on the board of the Italian Society of Narrative Medicine. She's a tenured professor of the narrative medicine at La Spaziana, Roma, and is teaching narrative medicine in other universities and institutions at a national and international level. She's the author and editor of many books, and in 2016 was a referee for the World Health Organization European for Narrative Method of Research in Public Health. So Maria is now going to speak to us about caring and living with Prader-Willi syndrome in Italy and integrating children, adults and parents' experiences through a multi-centred narrative medicine research. Thanks very much, Maria.
And so this project was not possible if we had not the cooperation of many Italian centers caring for Prader-Willi, so doctors, and also the People Association, Federazione Prader-Willi Italia, and also we had a sponsorship. It was very useful by a pharmaceutical company, which was Sandoz, for the growth hormone. But we haven't never mentioned growth hormone, so we were totally independent while running the study. This is what we are. This is the paper that we have published. For us, it was something very important because being Italian, we are already suffering from a kind of discrimination on publishing on peer-reviewed journals on English peer-reviewed journals. And this was published, hopefully, on British Medical Journal. So for us, this was really a success. And the title is Caring and Living with Prader-Willi Syndrome in Italy, integrating the different points of view I had of children, adults, and parents' experience through a multi-centered narrative medicine research. It was published on end of July, it was last year. So it was published during the COVID age. What is narrative medicine, first of all? I think that there are two main schools or no, I don't want to say schools, but approaches to narrative medicine. One is the one that we really embrace, and which is the, yes, I can say the Anglo-Saxon approach, which is to work on real narratives, real of the patients, of the people, of the doctors, and this is more focused not only on the disease, we will see, we'll come to this, but to the main aspects of how is to live with a certain condition and what it is the impact of this condition also on the microcosm of this person and macrocosm of this person. And there is another definition of Rita Sharon. She works at the Columbia University, and she uses more narrative medicine as a tool of education. And she's working with literature, text, to develop empathy and affiliations in the future doctors, future nurses, because she says that reading and moved by the stories of the characters of people present in illness narrative it's going to develop the imagination, and it's going to develop creativity. So it will lead to better, not to better, but to more effective care. So we have chosen the first approach, and when choosing the first approach, we are going to, I think this is quite useful for us to understand the roots of narrative medicine. We have to go back and using the anthropological point of view, and this was given by Arthur Kleinman, an anthropologist, Harvard, and I think this is very interesting because he was able to really categorize, I would say, give categories to the word that we generally use without awareness, pathology, or disease. And what author Kleinman remarked is that a disease is something which has to do really with what we call maladie, malattia, maleaptus, that is something abnormal is happening in the body. It has to do with the biomedical model. So for COVID, for instance, there is a virus and there will be a vaccine to defeat this virus. So it's very easy. The body is like a machine. It's like a computer and doesn't think, doesn't feel. And if we have feeling and thinking, it's just a matter of something which has happened just in the body that we have to repair when broken. Then there is the illness, which is the being ill. This is the subjective experience of a condition, including everything, including the feeling, the thoughts, the wishes, the needs, the projects, the emotions, everything is there. So including really the told and the untold of the person living a certain condition, living with a certain condition. And then there is the sickness, which is has to do with our world around, whether a particular condition is accepted or is discriminated by the environment, by the context around. So if being infected by COVID and once healed, have you told this? Did you tell this? Did you dare to say it, or have you had to hide it? Because what is coming out, for instance, for COVID, is that many people didn't say that they were affected by COVID. It's like there is a stigma to be affected by COVID. And so now coming to Prader-Willi, I don't want to spend words because you are the expert. Is not myself. I'm not the expert. I just want to say that what we wanted to do is through the narrative to understand the point of view of the endocrinologists, nurses, psychologists, educators, psychomotor therapists, social workers, dietitians, general practitioners, wherever possible. So what they do, and also to understand the living with by the children, by the teenagers, so the youth, and by the adults living with Prader-Willi, by their parents or relatives, some other relatives. So, and this is typical of, I would say, quality narrative research, is just not to focus the attention on one single point of view, like just that one of the children with Prader-Willi, or the family members, or the health professionals, but to combine together the different point of view to see whether there are alignment or what we say misalignment in understanding. Because if we are going just to work and just from one single point of view, we are not going to discover something very interesting. Yes, we will discover how just they live, which is fine. But it's we are going to seek whether there are harmonic transactions between the actors. So we have done two phases for this study. The first phases was before the COVID, so it was in 2018, basically. and 2019. And then the second update was during the COVID with 59 extra narratives. As I told you, we have taken the compositions could have been drawn by children who are not able to write, and also by adults and youth, and then by 112 members, family members, and 22 parallel charts. That is to write not in the clinical chart, but in a parallel chart. This is an invention of Rita Sharon. This is very interesting. Is you can write whatever you want about your person that you are caring, so your emotions. So you can write in a different way from the bureaucratic and clinical jargon that you use generally in the clinical chart. So this is the people that we have given voice to. As you see, there were, well, children and youth, 14 years and 13 years of age, and they were still at school. This is interesting, the age at diagnosis, 2.33 years, and the age when informed of the diagnosis, 8.33, 6 years. We had a prevalence of South because we had a strong engagement by Southern centers, then Northern, and then Central. This happened only for this study with Prader-Willi. I don't know why. Generally, we are more, let's say, balanced, but it's okay. Probably and possibly is because I would say that maybe since South is lacking of centers, of the numbers of centers providing care, the families were more engaged and they wanted to give narratives and give voice to this lacking situation of caring center. The adults, this also, they are still young, 26 years and 31 years. So one of the things that we love to ask to our people with a particular condition is to ask what they like to do. So because we think that we should focus also on what they enjoy, and this is very good, let's say, food also for the healthcare providers, so they know what their people love to do. So swimming, I'm very proud. I've won medals. Zumba, passion for nature and for the animals. So you see here, it's in Italian, this word cloud. I like piacere. I play music, swimming pool, piscina, the same company, compagnia, friends, color, canzoni, singing, read. So we can say that taking the concept of multiple intelligences, they have extraordinary visual spatial intelligence. They solve very, very fast puzzles, more, I would say, faster than ordinary people. They have musical intelligence, they love to sing, they have natural intelligence, they want to stay in the nature, and they have a strong sense of morality, of good and bad. And this is something that, well, it was amazing and wonderful also for us to understand how their narratives were very romantic, in the romantic genre. They want to have marriage, they want to have children, so they're not so much concerned by healing, by finding a drug or something that may heal them. You see, it's only 10%, but they were much more concerned about having full of emotions and feelings and being loved and loving life. Well, yes, some of them were concerned by having a job and feel good. I hope I feel good being with my parents, sister and grandchildren. So this is something very important, like yeah, this again, this sense of family, which is well, maybe a lot Italian and a lot Southern Italy, but so it can be related also to our cultural context. But this was something which was really striking. And what we wanted to do is that we wanted to defeat the stigma, which is related to the poor IQ. And we wanted to use other tools to measure intelligence, and we have used the use of what is called by Garner, sorry, it's written in the wrong way, frames of mind. So there are, as you can see, many different intelligence, and I mentioned some of them. I add here the body intelligence, the interpersonal, relational intelligence, introspective intelligence about emotions and their moods, natural intelligence, relationship with nature, and a sort of existential, ethical, moral intelligence, reflections of good or evil. Here, the food relationship, these are still the children. No, they are all of them, all put together. So what we have found that there is sort of gender effect, that women report a more complex relationship with food and talk about how they eat, while men focus more like on a bullet list point of what they eat. So if you read the narratives of male, they say today I had pasta and then vegetables and then this and then that, whereas the girls, they say, well, today I've been struggling for not eating, and so, but they know very well that it's an effort not to eat, and the good relationship is slightly, but just slightly better in women and than in men, and as you can see, the food relationship is somehow what is called is really a relationship with food more than what they're going to eat. So if we are going to classify the narratives of the patients, no, I don't want to talk about patients, sorry for this, but a person living with Prader-Willi syndrome, there are many different classifications to give to these narratives. What we measure inside the narrative or in the drawing is the kind of movement, is the kind of progressing toward the future, is the kind of acting, so coping factors. It's a kind of where they talk about their being ill or their discrimination. So if we use a classification by Arthur Kleinman, sickness, illness, disease, we see that they speak about their condition in a subjective way with the illness, and they speak also, unfortunately, about the being discriminated. Like sometimes I said, because I can't have friends, they don't call anyone, they're mean, they don't love me because I have the syndrome. So this is here, yeah. Then if we use another classification of Lohner, we can see that most of the same classification are moving and watching at the future in positive way, sorry. Oh my gosh. And very slightly, well, some of them unfortunately are regressive or stable, and they belong to the sickness generally. So these are what is they are related to being discriminated. Then here's, I don't want to explain this classification because it's a little bit complicated. It's really for scientific paper, but I want to say that most of them, you know, they're following the dietary regimen, taking their growth hormone, taking their medication, and they hope to be given, to be rewarded, restituted with their health back somehow. And few of them are in chaos, and a few of them are in kind of explorative situations. Why should I have this syndrome? What is this syndrome teaching to me? Most of them are doing coping, and this is good. So now we have done also a comparison. It's not the same, they're not the same people, but about what's happened during the first wave of COVID, and we have collected their narratives. So I think that we have to embrace what happened during COVID. We cannot think that nothing has happened, but they have now to elaborate the trauma, which school stopped, sporting and rehabilitation activities were suspended. Online, I was unable to learn and get active. No more school. Well, this was a lucky girl, I think, because she was living in the nature, in the garden. And so the people who lived in the countryside were luckier than people who were living in the city. The virus stopped everything. I stayed at home for many days without doing anything. I gained weight. This was again an extra problem. And we are locked at home. Schools are closed. We studied at distance. Okay. So the emotions of the people living with Prader-Willi syndrome during lockdown were basically sadness. Sadness is an emotion that you activate for loss of something, and then anger, and then serenity. And many of them did not practice. 38%. Half were able to practice less than usual, so we have really a problem, and only 15% were able to practice the same as before. So now I'm moving to the caregivers, family members, and I'm going to show the difference between also what was before COVID and during COVID. Well, it was very interesting. First of all, I want to highlight that we were just expecting 60 narratives, and we got 138 family members narratives. That was like possibly a venting. It was like, oh, someone is listening to my voice in a way which is not fragmented, because it's a national study. This group, because we had the Federazione Italiana Prader-Willi, and then we had the Società Italiana di Endocrinologia Pediatrica, so they will learn about this. Something is starting not just in a fragmented single, in a localized way, but more at a national level. And well, we know that basically we had more answer by women than men. This happens many times when we are carrying out narrative medicine studies. And we can say also the working situation was difficult for women. There were, I think I had to cut this, but there were, I would say, 50 or 60% of women who had to quit the job that they were doing earlier to take care of their children. Whereas for men, they were less affected, less impacted on the working side. Let's go to the first moment, which is a communication of having Prader-Willi, and these are the memories of the relatives. And so we haven't changed a word, we just translated them. So very told us that she was suffering from Prader-Willi, a very rare disease whose characteristics were compulsive search for food, and that led to obesity, very severe mental retardation, and would not exceed 6 years of age. The phone rings, is dismissed. This is confirmed diagnosis. Your daughter has Prader-Willi syndrome. Excuse me, but what is this disease? This is all before COVID. So it's not that the diagnostic should come by phone. Yes, it was all before COVID. And this is another one, which is a little bit more gentle, I would say. Unfortunately, we know almost about this. We only know that is that the patient have no hunger control, and the big problem is obesity with all consequences. So what are they going to do with all this information? Well, our doctors now are going to take care of the way to use, I would say, the right and the most possible right words, and also trying to find the right time to inform the relatives. Now, the burden of illness for caregivers. As you see, it's a huge burden that they refer. We didn't even go out for a pizza anymore. Constant struggle to make the grandparents understand the situation. This is something that is really moving. It breaks my heart to see my daughter when she meets someone with ice cream or a cake. I avoided taking her to places where she could see food. I took the dogs to eat in her absence. I made her eat alone and never with company. I need to unplug from time to time. So this was again a solution to take care of the caregiver. For me, it's become an obsession, like a jackhammer. You can't eat that. That's way right. You need a lot of patience, maybe more than jobs patient. Yeah, the work. So this is what I wanted to say. Sorry if I just anticipated earlier. 62 of parents had to change their profession after the birth. And in terms of gender, why 67% of others managed to keep their professional situation unchanged. It is women who make the most sacrifice, with only 37%, so 60% has to change, managing to keep their professional status. So they cannot also, you know, be, let's say, ambitious in terms of career, because when they are proposed also to move from one city to another city, they have to say no. So the Prader-Willi syndrome has for sure an impact of on work impossibility. And now after COVID, we have to think about this. So now the narratives during COVID of the caregivers. And so these are the narratives of 2020. So there's some total lack of possibility to relate with others, and not via Zoom brought my son to pathologically bind himself to me, considering me the only reference point. Well, this is active coping. We share most of the time trying to spend it actively. COVID arrived and all social activities were interrupted, school, sports, and friends. We tried to maintain social contacts using available technological tools, video calls, phone calls, chats. And this was good. I mean, this is coping. Now, as has started secondary school and the spread of the virus is accelerating, some new worries appear. How she will be able to cope with the school year with distance learning when not all the teachers are yet known. Yeah, they were not ready, and the class group was not formed. Again, despite being at home and in isolation, we tried to maintain our habits as much as possible. And there were, so yeah, some kind of different reactions. So there were some people, some parents who were like in a frozen way, some parents who were in a fighting way, trying to find some way to cope with this. Now, the problem was the healthcare facilities access. This was not just for people with Prader-Willi, but people with every other condition different from COVID, and even people with COVID. Yeah, we know that it was very difficult at that time to come there. And as we can see, there were visits were postponed, the green one. Visits were cancelled, the yellow one, I think, or the orange one. I canceled, some of them were canceled, the blue one. So there was a huge percent, I would say 70, 80% who are not receiving help, let's say, by their doctors, or they were just saying this. And it was, yeah, so-called medical disinterest. This is a perception by the parents. So we will see then afterwards a perception by the healthcare workers. The caregiver, yes, for sure, since he could not or she could not access to healthcare, the most occurring emotion was the apprehension, and then followed by acceptance and sadness, and then trust, and then serenity. So I felt lonely, abandoned, sad, thoughtful. I was so afraid of the whole situation that had arisen overnight with no reference point. Now we are just going to go very briefly through the point of view of healthcare and healthcare providers. First of all, what it is important, as you know better than I do, is that it's an equipe work, and the parallel chart was filled in by different point of view, like dietitian, endocrinologist, physical medicine, nurse, pediatrician, endocrinologist. Unfortunately, we couldn't put on board the general practitioner. So we understood that there is no connection with general practitioners and with social services. So this is something that we have been pointing out in our publication, the BMJ, on the British Medical Journal, that there is a wonderful equipe work, but with very poor connection, since they were not mentioned with the medical, with the social services and the general practice. So this equipe is quite alone. And during I felt during the COVID apprehension, it was the first, vigilance, fear. So this is how they felt in their narratives during the COVID. And COVID came. Everything was blown up. Hospital shifts were revolutions with increased workload, and all scheduled activities were blocked. But we know that increased workload went to COVID and not to the other ordinary scheduled activities. I went out when just justified and for special reasons. Hospital activities was eliminated for obvious reasons. The boys stayed indoors and had serious problems with food and weight management. We started out with a video course. The parents send their consent to the video, and I carry out the control visits and send the GH treatment plan. So the telemedicine was a good way to keep in touch with these families all over the first wave and second wave and third wave of COVID. And so when I'm referring to third wave, I'm referring to up to April 2021. So this year. So it's almost 1 year. And so have you sent communication? 73% said yes. 91% said yes, I apply telecare. Have you visited during the first, have you visited the Prader-Willi person at home? None, nobody. Outpatient visit, yes, but just after. And so did you have difficulties in care protocols? Doctors are quite saying no. And difficulties in drugs, no. So when I was saying misalignment, we have to consider that this was the perception by the caregivers, the family members, and this was the perception by the doctors. So the doctors were there, but we don't know how much they were able to reach and to calm down, to soothe down the anxiety of these parents. And this is one of the scope of collecting different point of view. So now I'm approaching the end of this presentation. I hope that it was somehow useful. For sure, narrative medicine has to take into account that it's always a matter of local context. So what I'm referring to is Italian narratives. So if we are going to do again this kind of using the same plot to collect narratives, I didn't went in the plot that we used to collect narrative. They were very, very easy. They had just some little prompts. So like I am, what I like to do, I like to, and then they told me that, and now at school or with my friends, no, not my friends, so the people around me. So because you were saying my friends, we are already conditioning. You were saying the people around me were using natural word, neutral word for the future, These are quite, universal. They belong to a universal language, which is called natural semantic metalanguage, and it was found empirically by Australian linguists in Canberra. And so we are always using this kind of words because they are not, we cannot say they're not misunderstandable, but they're very, very easy to, and they are evocative words. They invite to narrate oneself. So, but if we are doing it in another country, like, I don't know, in Australia, in France, in UK, maybe we could expect different results. So there was a huge tendency to share their own experience, functional and dysfunctional aspects in the care and social services in Italy. The relationship with food in the pre-COVID era was easier to manage as a result of many distracting activities in the children and young people. There was a social problem with women. 62% of them had to change before COVID their work. Well, the treatment with growth hormone was used, and also other drugs are considered useful. And there is a problem in how there is kind of cruelty of branding and predictive words, or your son will suffer from mental retardation. And this is why we open up to different intelligence, multiple intelligence. Yeah, what happened during COVID is that COVID suspended time and outside activities. And so the caregivers were called upon to invent creative solutions. And they had also postponed care, while the professionals declared that they have been present in the places. But one thing is to receive a telecare consultation, and one thing is to be physically present, to go physically in a center of care. So it's also a matter of probably of culture, of lacking of digital culture, maybe. And another thing that I not mention, which is always reported, and this was at the beginning, especially of the first wave, that the COVID was called as a monster. This is also in other narratives that we got from patients with the chronic obstructive pulmonary disease, from patients and from other citizens at the beginning, and I'm in the end of the presentation. The COVID in the first wave in Italy, we were the first European country to be affected by COVID, and it was seen as a monster, not even as an enemy to fight. Later, it came as an enemy later, and this was when we could, let's say, fight it with, some kind of protocols. So the vaccination came, but at the beginning, it was seen like a monster, something like coming more from an horror movie than a fight or a war. And that's it. I think that, there were multiple intelligence should be more used to get out from this mental retardation stigma, and other intelligence should be also explored in the parallel chart and also in the clinical chart. And I think that's all. And I finished my presentation.